Hi, and welcome to the January CE Appetizer program titled White Bagging Implications in Outpatient Infusion Setting. This program is accredited for both pharmacists and pharmacy technicians. My name is Trish Wagner. I'm the Vice President of Professional Services for ICHP. Glad to have you all here. I'd like to introduce our speaker, Dr. Shannon Koch. Dr. Koch is the Pharmacy Revenue Cycle Manager at the University of Chicago Medicine, where she manages all medical drug reimbursement processes, including pre-certification, claims denials, site of service, contracting, and patient assistance programs. She received her Doctor of Pharmacy degree from Nova Southeastern University in Florida, and completed a PGY1 residency at Memorial Regional Hospital in Hollywood, Florida. Dr. Koch is also a board-certified pharmacotherapy specialist. Dr. Koch?
All right, thank you, Trish. Well, good afternoon, everyone. Today I will be presenting on the hot topic of white bagging implications in an outpatient infusion setting. I have nothing to disclose this afternoon. So these are our learning objectives for the pharmacy technicians. We will be able to define buy and bill, white bagging, clear bagging, and brown bagging terminology, and then recognize each scenario above in a patient example. As far as pharmacists, we'll be able to explain the implications of pharmacy sourcing insurance policy that apply to a patient's case, and then describe a multi-team process for how to manage white bagging. So we'll go into what is buy and bill. So I'm sure you've heard this terminology before, or maybe you haven't. This is when the health system will own the entire process for procuring, storing, managing, administering, and billing the medications. Basically, this is when you would purchase it from your supplier. The patient would come to your facility for the medication. You would go ahead and supply the medication and administer it and then bill for it. So therefore, the hospital takes on the financial risks of inventory costs, any sort of medication waste, and then the potential of no reimbursement. So to define clear bagging, so this is when you have a hospital affiliated community or specialty pharmacy on site, and you would deliver a patient's prescription directly to the clinic or the provider's office to administer. So this would be completely managed in-house by one of your own pharmacies. So white bagging is when a specialty mail order or outside pharmacy delivers a patient's prescription directly to the provider's office. An example would be CVS specialty shipping an outside medication to a provider's office. The patient comes in for the visit and then it is administered. So brown bagging, this is when the patient actually brings in their own medication from an outside pharmacy. Most institutions, we prefer not to allow this just because we can't manage the storage of the medication. We really do not know, what has occurred between when the patient got it and when they bring it in. This would typically only happen if it's maybe a drug that, the hospital cannot obtain and the patient has to bring it in while they stay at the hospital. So poll question number 1, this is for pharmacy technicians. So what is clear bagging? So it's either A, clear bagging is when the patient brings in their own medication that they filled at CVS to be given by a nurse. B, clear bagging is when a patient brings in all of their medications to their doctor's office for the nurse to reconcile. C, clear bagging is when a facility's on-site retail pharmacy fills a medication and is delivered directly to the clinic for administration. Or D, none of the above. Okay, so it looks like most of you answered correctly. The answer is C, clear bagging is when a facility's on-site retail pharmacy would fill the medication and then it's directly, given to the clinic for administration. A and B were not correct because the first example would be an example of white bagging, and then B, this is an example of brown bagging. All right, so we will move into the insurance market trends, and then we'll just kind of go down that route of looking at patient case examples and how you should manage this as a healthcare facility. So as far as the trends, so for the past several years, the infusion product market has been moving patients from hospital-based care to alternative sites of care, just as a cost savings initiative. And another strategy that's why we're having this presentation today is that they've started to require certain high cost medications that would normally be billed through the medical plan to now be billed with the insurance's contracted specialty pharmacy. So this would be an example of white bagging, or you might hear the terminology pharmacy sourcing. And the CEO in early 2020 of United Healthcare actually stated that the insurer sees an opportunity to shift more than 20% of medical spend to what it terms more effective sites. So basically, what does this mean? So right now, the policies are targeting high cost infusion drugs, mostly biologics used to treat autoimmune conditions. And recently, Cigna added cancer agents to this. So they'll be required to either be filled with a contracted specialty pharmacy, an example is United Healthcare and Optum Rx, or shifted to an alternative or lower site of care, which would be physician-based or a freestanding facility or home infusion. I will not go over sites of care, lower sites of care on this presentation. I'm just going to focus on the white bagging, but that is another trend that we've seen. So as far as white bagging implications, so I'll dive into care coordination, safety and regulatory, and then as well as financial. So this is a pretty complex chart. I actually made this just fully based on experience. So for the last year and a half, my team's been managing all of these pharmacy sourcing policies and developing workflows as we go. So I'll just kind of go over this. So in the blue would just be the pre-certification process. And then in the red stop signs, it's what you should really think about at each step of the way. So as far as how the process goes, so right now, a facility will typically submit prior auth to the medical plan first. Then the medical plan will notify the facility that the medication must go through their contracted specialty pharmacy. The pharmacy or the clinic is then notified to submit the authorization to the specialty pharmacy. Medication is authorized through the pharmacy benefits, and then the facility appointment must be timed to a later date for when expected shipment will arrive. And you have to make sure the zero charge order must be entered. I put a penny there because that's actually what Medicare recommends so that you can actually bill for the visit itself. As far as like the stop signs, these are things, and I'm sure everyone's experienced if you've had to kind of go through this process with a patient. But as far as when you're obtaining the authorization, a lot of times medical plan reps, they actually are giving misinformation. And they might state the medication is covered as buy and bill when it is not, or that no auth is required, because in their system, it may show that, but then there's, a certain stipulation, it has to go through the PBM. So I would implement recorded calls. And I also will go through exact questions that you should be asking the insurance so that you can truly make sure that you know what the benefits are. And then once you are notified, typically revenue cycle is a separate team from pharmacy. I would say Chicago Medicine is pretty unique in that pharmacy is integrated into revenue cycle to help with prior authorizations. So you do need some sort of like formal process between pre-certification and the clinic or pharmacy departments, or you could train your rev cycle team to do pharmacy auths. That's just not something that they're experienced with. So that would require training. And then you would need to consider clear bagging if you want to create a workflow, trying to get overrides through your own specialty pharmacy. So then when you're going through the auth through the pharmacy benefits, I'm just kind of putting it out there that the facility staff has to do all the outside follow-up. So they're following up on the pharmacy auth, doing the patient education, any sort of copay card enrollment. Then there's another step of sending over prescription and setting up shipment. So it's very time consuming to go through this process. It's extra steps. And then lastly, you do have to have a tracking system. So you do have to make sure that somebody is tracking these shipments, that they're coming on time, and that you have the appropriate free drug ERXs built out. If you're accepting outside vials and you have picture software and certain scanning software, you would also have to make sure that the label is scannable, and you could somehow create dummy labels or something for the free medications that are coming in from, well, not free, zero charge medications from these pharmacies. So a lot of care coordination. So safety and regulatory considerations, I won't read this word for word, but these are just some things that you would need to consider. I didn't go into 340B on this call because it's only 30 minutes, but 340B compliance is something to consider as well. When you have outside drug mixed with 340B supply, you would need to make sure it's separated. So you want to consider, the drug procurement process. Like I said, patient tracking system. Has it been stored appropriately, and is it compliant with the Drug Supply Chain Security Act? If a safety recall occurs, do you have a process in place with the patient and provider? I think this one is like a question that everyone thinks about, and it's really up to the institution, but do you allow a patient to infuse using your own stock if the medication hasn't come in? I think that would really depend on your financial risk as an institution, and if you have a good working relationship with this pharmacy and you would trust that they would replace the stock if it didn't show up. Also, do you allow a product to come into the clean room? That's not your normal acquisition process. I already mentioned barcode scanning, and then you do want to make sure you have these charges appropriately billed, and probably have a second system to double check these charges as well. You can get in a lot of trouble if you're double dipping, billing the pharmacy plan, the medical plan. So there's a lot of things that you need to, put into place. So financial, as I just went over that long slide on time spent on care coordination, is dollars spent. At the end of the day, the institution is spending all of this time. I mean, I've spent hours on cases just to get the patient the medication and get it all set up. That's dollars for the institution. When the insurance misinformation comes in, any errors, that is 100% write-off risk. Although you can probably appeal a lot of these, appeal takes time and it takes staff. And if your institution doesn't have a bunch of denials team members working these accounts in real time, you could end up with, I've seen cases where we've had 5 or 6 denials come in and we weren't notified until the patient had already received about 4 or 5 months of treatment. So you just really have to be on top of it now with these drug codes and making sure that you're monitoring the denials and real time, addressing the situation on the prior auth side. And then the obvious one is lost drug revenue. You get $0 on the medical plan reimbursement. You do get a little bit for the administration, but all of the work and the care teams and everything that goes into getting this patient set up, they're really, the revenue is not there for the system. So poll question number 2, this is for pharmacists. So which of the following are true about white bagging? A, white bagging requires additional staffing resources to procure drug. B, white bagging is not a safe practice since drug procurement does not follow standard processes, which could result in inappropriate storage temperature, wrong dose shipped, or missing medication that leads to delayed patient care. C, white bagging is the practice of allowing the on-site hospital pharmacy to fill the medication instead of buying direct from the wholesaler. D would be A and B, or E, all of the above. Okay, so the answer is actually D. Both A and B are correct. So white bagging does require additional staffing resources. And then white bagging is, I guess this is a little subjective, but it is, in our view, not a safe practice because it could result in inappropriate storage or delayed patient care. And then C is, this would be clear bagging. All right, so I'll go into some patient case examples. So this is an example where a patient was prescribed Remicade infusions. Blue Cross Blue Shield employer sponsored plan opted in to fill all specialty infusion drugs with CVS specialty, and the plan approved medication with just a note at the bottom, must fill with CVS specialty and ship to facility where drug will be infused. I will say you have to be very careful with some of these plans. They will say authorized, but then have stipulations. So always reading the actual approval letter is unfortunately the way things are going with some of these medications. Poll question number 3 for pharmacy techs. This case example is asking the hospital to do which of the following practices. And again, the insurance was asking the hospital to accept outside vials from CVS and ship them to the hospital. So it's either A, brown bagging, B, buy and bill, C, clear bagging, or D, white bagging. It is D, white bagging, because we are accepting outside medication from an outside pharmacy. So we'll continue with this case example. So what would you do basically? I guess it depends on your institution, if you have a white bagging policy or not. But if you're looking for an override, this is how we went ahead and proceeded. So you would call the medical plan to discuss the override process. Do not call CVS Specialty. They will state they can't do anything for you and they'll just route you back to the medical plan. At this point, you've kind of already, what's odd is that you've gotten an approval almost, but you have to fill a CVS. So it's not exactly, you can't do a peer-to-peer in some of these cases, which makes it confusing. So you would need to submit a fax as additional clinicals. So that's what you would ask the medical plan, if you can submit additional clinicals and get this re-reviewed. Otherwise, it might get tossed out as a duplicate or like, why are you sending this again? We approved it. So I would submit, if you have a white bagging policy, well, if you don't have one, I'll go into that, but you would need one. That would definitely help to get the override, along with a letter of medical necessity, just stating why outside medications will not be accepted. Hopefully they will approve it. We have been successful in some cases. Also just putting in the letter that the infusion centers in the community will not accept their product, which is honestly true from my experience. I won't go into like specific names of infusion sites, but a lot of times they don't want to take the patient either, because there's no revenue in it for them. And then it is a lot of coordination to get those vials in for them as well. And then if you still face the denial, you can try to escalate it to a manager. Oh, right. With the same logic that we just can't find a place for the patient to get treatment. I usually just kind of put it back on them. I mean, if you can find a place that your vials will be taken, then, kind of just put it on them to help you. And typically they can't find anywhere that's convenient for the patient for them to accept the vials. So we've been able to get overrides that way. I guess it just depends on like what area you're in. This is another patient case example. So I'm sure everyone is aware of the United Healthcare policy change on October 1st, 2020, where they started requiring vials to be filled with their contracted specialty pharmacies, or they would have to be transferred to a lower site of care. Some of you may be okay with United Healthcare because they are still allowing, lower sites of care. So if you are set up for physician billing already, then you might not be, facing this issue. But if you are billing as a hospital level of care still, then this probably affected you. This is just an example of being proactive. This was an example where a pharmacy team leader got notified by Genentech that this policy was coming. I probably wouldn't rely on, a drug rep to notify you of policies and have a proactive approach set up for monitoring the policies. But we were notified that way. And then we provided this information to a finance contracting team. And then this is just an example of, if you're successful, the managed care team can reach out to the payer and just state this goes against our bylaws for safety reasons, and then work together to obtain an exemption for our hospital. This was a different hospital that actually had this case example, but just wanted to say this is something that you can do. To go further on that with managed care inclusion, so you should always be involved with managed care as pharmacy, faces drug policies getting a lot stricter, and you have biosimilars coming to markets. You really need to have that relationship. So the term white bagging is usually a pharmacy only term, and it's not found anywhere in contracting. So we really need to identify this language earlier on in the process. And then, like I said, just have that ongoing relationship to try to appeal this to payers. And then attending leadership meetings is very important to keep, if pharmacy or pre-certification managers keep managed care in the loop of payer policies requiring pharmacy sourcing. A lot of times this is a gap in some systems. The policies are not being tracked, and it's more real time of what is happening on a day-to-day basis. And I think that really helps leadership understand, the problems that we're facing. So it's always good to keep them in the loop. I will say with contracting payers, you have to be careful if your contract states like we can buy and bill for these drugs, they can switch the benefit to the pharmacy benefit. So having like verbiage in the policy in your contracts actually stating that for these drugs, no matter, the benefit change, we can still provide these services. So here's some pre-certification tips. So this is what I was talking about earlier of things to ask. And, a lot of pharmacists or pharmacy techs may have never called a medical plan before or know how to get to the pre-certification line. So understanding the patient's insurance, medical versus pharmacy, as well as, where to locate that in your electronic medical health record. And then also locating the payer contact information. So you'd always want to call provider services, and it's typically located on the back of the patient's benefit card. Or your pre-cert team may already have an Excel sheet of all the phone numbers. Sometimes the cards are never scanned into your system. So, they may have like an easy number for you to call. And then just educating all staff that medications must come from the hospital pharmacy if a policy exists. I find in like large healthcare systems, it's easy for different clinics to be doing different practices. So education is key to keeping that policy in place. And then when calling the plan, so these are the things that I would always recommend to ask. Unfortunately, it's a lot of questions, but especially for all the specialty infusion drugs, this is just where we're at. So you do want to state that you're calling from a hospital. If you are a hospital, of course. I don't know if there's other healthcare facility pharmacists on here, and then state that the medication has a J code or a Q code. Now, some of the biosimilars are Q. And then just make sure it's the medical benefits department for outpatient infusion. And then these are just things that you'd want to ask where you could be like misguided. So making sure that they are with the medical benefits with every transfer, and then asking them, are there special instructions for billing this? Are we able to obtain buy and bill? So using that terminology is important. And then is there a site of care policy or sourcing restriction for this drug code? So asking all of those questions will really help narrow it down. And I have called before and I'll get told no prior auth required, and I don't even trust it. I'll just keep asking further questions. Is there a policy? Can you check further on these two items for site of care sourcing or through a pharmacy? And then they will look further and there actually is another policy that they have. And then as far as locating insurance policies, so this is actually, sorry to clarify, not patient policies, but actual like medical plan policies. So I do think a lot of people think I have, like, I'm the gatekeeper to policies, or as if I have some like secret access. I don't. Everything is through Google. And the reason I do that, or I go to the main site, is because they're constantly updated. So you don't want to save old PDFs of medical policies. I never recommend that. I always recommend going to the site for the insurance plan site for the most up-to-date medical policy. So you really just need to Google the insurance plan name, brand name, and then the medical policy. So Aetna, Ocrevus medical policy, it will pop right up. Or if you're trying to monitor site of care policies, same thing, site of care. Or if you just search the insurance plan site of care, you'll find all of the site of care policies online, and it's pretty easy to find and track. So what I've actually created is an Excel sheet for every month. I'm tracking for certain drugs where insurances have product preferences, so biosimilars, site of care, even iron product preferences, like tracking all of that. Fortunately, you just have to be organized with it and track it monthly and make sure your formulary and the outpatient world has, all of the products that the insurance are requiring. So then you'd want to create an action plan. So first you have to decide, will you allow white bagging or not? Obviously, my bias has been towards no throughout this entire presentation. And at UChicago Medicine, we do not allow white bagging. We do have a policy against it. But, I'll just go into either way, what you would do. So if you do end up allowing white bagging, kind of everything I talked about earlier, you'll just need to think about. So you would need a pharmacy tech to manage shipments. That's 100%, like you have to have that process. Some sort of SOP, like for care coordination processes, And then revenue cycle items, assuring charges are appropriate. If you have a 340B program, monitoring that, assessing any lost revenue. And then you still want to be always engaging managed care. So if you are going to allow this, you still want to engage managed care. I will say though, if you do allow it, payers are more likely, if you haven't taken a stance and you've allowed it and then you go back, and you've tried to now do a contract, it might be harder. If you don't allow white bagging, what I would recommend, if that's the way you want to go, definitely create a white bagging policy. Educate your clinical staff, keep engaging managed care to get those contracts to be an exempt site, and then track insurance policy updates. When you do create an SOP for insurance escalation processes, I do recommend having that. You would want to address clear bagging. So if you're going to allow clear bagging through your own specialty pharmacy, that's a whole process in itself that I probably could have done in 30 minutes. We had to create a whole, workflow for it. And I will say it is still time consuming, but it is possible. And then address the send out process if the override is not possible. And then as far as key contacts to know, I kind of went over these, but I would say overall pharmacy just needs to be kind of the link between clinical teams and revenue cycle and managed care. So those are all the teams that should be working together and constantly in communication. When, I started this job 5 years ago, I feel like, revenue cycle is in its own world, and it took a lot to figure out what's happening and, claim denials, not real time being informed of them. So just having that constant kind of communication between all of these teams is important. Okay, just wrapping up here. So just recommend to take legislative action. Like I said, we've taken the stance. White bagging just is not safe practice, and it's very time consuming for the institution and delays patient care. Right now, this is as of November 24, 2021, there are states successful in outlawing, and I will be happy to say we are bringing some legislation in Illinois this year. So talk to your state reps if you want to get involved. I'm sure I can let you know, or Trish can let us know, but Massachusetts, Louisiana, they've actually outlawed this. So I'm hoping by 2023, this will not be a hot topic anymore. This is just FYI, we do have a prior auth reform act that just got implemented January 1st. So it's kind of perfect timing to add an addendum clause to this, to put in a white bagging ban. And if anyone doesn't know about this act, it's amazing. It was brought on by the medical board. Take a look at it. It's great. It promises us within 72 hours. So if they're not holding up to that, you can actually bring up this law. Okay, so last poll question. So which of the following are true about how to create a multi-team process to manage white bagging? So A, involve managed care for any insurance policy changes that require pharmacy sourcing. B, create a clear process with pre-certification and clinical teams for how to manage patients with these insurance policies. C, connect with the revenue cycle denials team so that they can notify you of claim denials that come in due to pharmacy sourcing. Or D, all of the above. Okay, 100% of you got this right. So I think this one was pretty obvious, but the answer is D, all of the above. All right, so key takeaways, establish an internal policy and procedure. You should incorporate this into some sort of medical staff bylaws. You should work real time, basically each patient case, and then always, involving managed care as well. And then these are some topic resources. So ASHP, ACCC, and NABP have all taken stances on this, and they have great ways for you to get involved if you want to get involved in any sort of legislation, and so does ICHP. So these are some good resources just to read up on kind of the trends out there. All right, does anyone have any questions? I know I spoke so fast as I tried to put a very long topic into 30 minutes.
Can any argument be made that these various bagging protocols policies increase patient compliance?
That's a good point. So if you can keep the patient in-house, supplying your own medication, then it's better for compliance. I do think like the insurance would state, well, if we supply the drug, you can still, and you actually accept it, then the compliance would be fine as well. So they may say that, but our policy was more focused on safety. And it's just a lot of care coordination to accept these outside medications. So I would say yes, if you have to send the patient out due to a policy, I would say definitely patient compliance would go down.
Don't see any further questions. So thank you so much, Shannon, for that great presentation and all that important information. Got lots of thank yous coming through here to you for your insight on this topic. And I hope everybody gets involved legislatively too to talk to their representatives about white bagging.